Hello students. So today let us see about a condition called a housemaid's knee or a carpenter's knee, popularly known, but actually it is a pre-patellar bursitis, inflammation of a bursa. So already we have seen in the last classes that a bursa is a fluid-filled sac which ensures that there is less friction between the body parts, or it reduces the friction between the structures. So the pre-patellar bursa is located superficially between the skin and the patella. And the inflammation of this particular bursa is called bursitis. The inflammation can take from either an infectious nature or from a non-infectious nature. A direct fall on the patella, an acute trauma, repeated blows of friction on the knee are some of the factors for this condition. Other causes includes infections of low-grade inflammatory conditions such as gout, syphilis, tuberculosis, or rheumatoid arthritis. Patellar bursitis often occurs in specific jobs which involves a position where they work on their knees for a prolonged period of time, such as miners, gardeners, carpet layers, also mechanics. So let us see about the clinical anatomy. So in this picture you can see again the structures which is there in the knee joint. You can see the femur bone, the tibia, the fibula, the articular cartilages of tibia and femur and the patella, and the surrounding structures, the ligaments, the meniscus, the other structures called the retinaculum and the bursa. So here you can see we have the bursa prepatellaris. So that is the between the skin and the patella. Then you have the bursa infrapatellaris, which we will see in the next class. And also you can see the other ligaments surrounding here. This is the iliotibial band bursa. So these bursas are located in these structures where they contact with each other, like the muscles when they come and become tendons and they insert. So sometimes the bursa is present in between the insertion tendon and the bone, sometimes between the ligament and the bones, in order to ultimately reduce the friction. If you go to see the epidemiology, it affects men more than women, and it can emerge at all ages. 80% of the people with prepatellar bursitis are aged between 40 to 60. One-third of the prepatellar bursitis are septic and two-thirds are non-septic. And infectious prepatellar bursitis emerges more often with children than grown-ups. Prepatellar bursitis often occurs with at least an annual incidence of 10 to 1 lakh. The incidence of prepatellar bursa is probably underestimated because most of the cases are non-septic, and only patients with more severe cases of prepatellar bursitis require admission in the hospital. So the causative factors are direct trauma to the anterior knee, frequent falls on the knee, constant friction between the skin and the patella, and by the impact that damage the blood vessels in the knee result in inflammation and swelling, and actually a bacterial seeding of the bursal sac caused by an hematoma is rare. Then another cause is infection. A septic prepatellar bursitis is a break in the skin near the bursa which leads to swelling and pain around this knee area. So this happens when a bacteria, for example Staphylococcus aureus, 80% of the cases which Staphylococcus aureus is responsible, have passed across the soft tissues from a break in the skin, begins to multiply within the bursa. And when a bursa is infected, it can probably cause pain, fever, tenderness, all the inflammatory signs. Also an increase in the WBC. Also there may be coexisting or inflammatory disease like RA, gout. Now what is the clinical presentation? Is mainly pain, swelling, warmth around the knee, limited range of motion at the knee. If it is by infection, then pain is associated with fever and chills. These are the clinical presentations. Coming to differential diagnosis, we have to also rule out some other conditions responsible for the knee pain, like the medial collateral ligament injury, the lateral collateral ligament injury, osteoarthritis, pace, Ansonius bursitis, that is another bursa, located around the knee joint inferiorly. Then you have the posterior cruciate ligament injury, rheumatoid arthritis, patellar tendon rupture, chondromalacia patella, which you already have seen the degenerative changes in the posterior side of the articular cartilage of the patella. Then you have the patellofemoral pain. And the diagnostic procedures, mainly we go for a proper history collection and examination, like the palpation, knee pain, swelling, then CT scan, X-ray and MRI are the best possibilities to rule out of a fracture or a soft tissue injury. And then if it is uncertain whether or not the bursa is infected, arthrocentesis can be done. It is typically done for 3 reasons: to make a diagnosis, to relieve the pressure in the joint, and to help the elevate or reduce the pain, and excess fluids needs to be removed before a therapeutic injection is given. Coming to the outcome measures, we go for the visual analog scale, KOOS questionnaire, which consists of 5 components: the pain, other symptoms, function in daily living, ADL, function in sport and recreation, and knee related quality of life. Each question gets a score from 0 to 4, and a normalized score is calculated for each subscale. Anterior knee pain scale to measure the functions. Then we have to go for the physical examination, which involves for the checking of the warmth around the knee, erythema, tenderness, swelling, pain, range of motion. When there is a limited ROM or because of the swelling, a surgeon may recommend using a needle and a syringe to remove the fluid from the joint. The fluid can be sent to the labs for culture, whether or not the bursa is infected or because of some infective organisms. Common tests for infective organisms are gram stain, white blood cell count, and then glucose level tests, and which is done to rule out the septic bursitis. Then medical management is primarily to treat the pre-patellar bursitis depending on the cause. Primary goal of treatment is to control the inflammation. Conservatively, we follow the RICE protocol, 72 hours, and the medications including non-steroidal anti-inflammatory drugs, topical medications, creams, sprays, gels, patches can provide pain relief, and those which are directly applied to the skin over the knee. To reduce the gastrointestinal side effects that can be caused by the oral medications, topical medication may be a good choice. Antibiotics are given to treat the infectious pre-patellar bursitis. Also, corticosteroid injections are used. If all these measures are not sufficient or fail, then we go for the surgical management, and it is an outpatient arthroscopic bursectomy, which is done under local anesthesia, which is a quite effective procedure. Arthroscopic or endoscopic excision of the bursa has more recently been reported to have satisfactory results, with less trauma than open excision. The operative procedure, the patients are placed in a supine position, and a tourniquet will be routinely applied on the thigh and not inflate until necessary. Skin will be prepared in an aseptic manner over the whole lower extremity. Solution will be infiltrated at the portal site into the cavity, respectively a 1% xylocaine solution with 1:1 lakh epinephrine. For a monitoring, 2.7 mm 30-degree endoscope will be used, and a 2.7 motorized shaver to remove the thickened synovium. 2 or 3 2mm portals will be made. An anterior medial portal and an anterior lateral portal are routinely used, and if necessary, a superior lateral portal is also made. To make a 2 mm incision of each portal, a number 11 scalpel will be used, and after this the trochlear will be inserted the trocar will be inserted into the cavity and the other instruments will follow, which is done generally in arthroscopic procedure. The bursa cavity and the synovial thickening directly visible by the endoscopy. Motorized traver inserts through the other portal and the total synovectomy is including the bursa will be performed until the pathological lesions are removed. When all procedures completed, the portals will be closed with adhesive tape without any suture. Anterior knee area is dressed with loosely unfolded gauze, padding, bandage are applied. PT management RICE protocol elevation method is commonly used for pre-patellar bursitis. The rest phase consists of a short period of immobilization. This period should be limited to the first days after a trauma. Resting will reduce the metabolic demands of the injured tissue and will avoid increased blood flow. Use of ice will cause a decrease of the temperature of the tissues, including vasoconstriction and a limitation of the bleeding. Also, the pain will decrease because the cold will increase the threshold levels in the free nerve endings and at the synapses. So we all know it works under the pain gate theory. So the compression will decrease the intramuscular blood flow to the affected area and also reduce the swelling. And lastly, there is the elevation, and this ensures the hydrostatic pressure will decrease and will reduce the accumulation of interstitial fluid. This part of the RICE principle also decreases the pressure in the local blood vessels and helps to limit the bleeding. However, the effectiveness of this RICE method has not been proven in any randomized trials. Once the initial inflammation has reduced, a program of stretching and strengthening is very much useful to restore motion and improve the strength and to reduce the stress on the tendons and the knee joint. Therapeutic exercise to strengthen and stretching the muscles is important. This includes isometric contraction of the quadriceps, and then it should be practiced by the patient at home 1 to 3 times a day. Objective of rehab is that the patient can resume their everyday activities. Then the isometric quadriceps contractions is properly taught to the patient with a proper feedback, and for that the therapist has to feel the contraction by putting the fingers on the inner side of the quadriceps and to feel the contraction. If the contraction is not enough strong, then we have to ask the patient to increase the contraction and then to hold it for 5 seconds, and the exercise can be repeated 10 times as hard as possible. Also, the stretching of quadriceps muscles is a good exercise. Reduce the friction between the skin and the patellar tendon. And ultimately, prevention is better than cure. In order to prevent pre-patellar bursitis, we should avoid injury or an overload of our muscles. It is very important to do an appropriate warm-up and also an appropriate cool down while playing sports. And for example, if any sport like volleyball, it is advisable to wear knee pads, or the direct contact sports or sports where you have the risk of too much of falling. And another important thing is to avoid pre-patellar bursitis, to check if the flexibility of the knee and the strength of endurance of the leg muscles stays optimal. So these are the few references you can go through, and already we have discussed in the class. So any doubt regarding this is a very small topic, nothing much of complications. Just I hope this video will make you understand more better, and we have seen how it happens, what are the causes, what are the risk factors, how to deal with the condition, what is the conservative treatment, what are the surgical procedure, which is a very minor procedure of down in the as a OPD outdoor patient, and then what are the physical therapy measures taken. So I hope this video will help you to understand better. Thank you so much for watching this video.